The following podcast is part of a certified educational activity titled Changing the Future for Families with Homozygous Familial Hypercholesterolemia, Long-Term Benefits of Early Diagnosis and Treatment for Homozygous Familial Hypercholesterolemia. Access the entire activity and complete the post-test at peerview.com/MRJ860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Patrick M. Moriarty from the University of Kansas Medical Center in Kansas City, Kansas. I'm professor of medicine and director of the Lipid, Atherosclerosis, and Apheresis Center here at the university. And I'd like to welcome you to this program on changing the future for families with HoFH, homozygote FH, through early diagnosis and appropriate treatment. So our goals today is to recognize how HoFH differs from other types of lipid disorders, learn how to screen for and diagnose HoFH, including the so-called cascade testing relatives, initiate intensified lipid-lowering therapy in collaboration with lipid specialists, and to help patients and their families access specialists and the resources needed to treat HoFH. So let's start off recognizing HoFH underlying genetics of HeFH and HO. So for classic FH, four major gene associations with it: LDL receptor deficiency or dysfunction, which is roughly close to 95% of all FH, so-called ApoB defect, which is associated with the ApoB lipoprotein bound to LDL, which does not recognize the LDL receptor on the liver that takes in the bad cholesterol. PCSK9, proprotein converter subthalixing checksum type 9, which is a protein that if in excess can destroy LDL receptors quite extensively, which will result in a lack of LDL coming into the liver to be metabolized, thereby increasing your levels of LDL. Again, this is a very rare form, but it's existent. And all three of these are autosomal dominant. And the other one is an LDL receptor adapted protein 1, which is autosomal recessive. And it's fairly rare, and being that it's recessive, it needs to have two genes to be significantly phenotypic. There are some so-called FH phenocopies, which won't go into too much detail: ApoE, ApoCG, ApoCG 5 and 8, and LIPA, lipoprotein deficiency, and I'll talk a little bit about these later on. So how do you differentiate HoFH from heterozygote FH? HeFH or heterozygote is one gene from one of the family members. Baseline LDLs could be close to 200 or higher. Onset of cardiovascular disease is young compared to the general population, the 30s, 60s. Most respond to pharmacotherapy, in common in about 1 in 250 people. Homozygote FH, you need two genes from parents. LDLs are over 400 milligrams per deciliter. And because of the early onset of these lipids, childhood disease is not uncommon, and their response to medical therapy presently is not the best. And it's found in 1 in, likely, 300,000 patients worldwide. So patients with HoFH have ACS, atherosclerotic cardiovascular disease events in childhood, as I mentioned. This is a study looking at 277 patients. Mean LDL level was 444. Only 26% had an FH diagnosis, and only 20% were diagnosed with ASCVD. And the lipid-lowering therapies for these patients was not very dynamic. As you can see in this study, 40% were on no therapy at all. 1% was on ezetimibe, 19% on high-intensity statin, 10% on low-intensity statin, 11% were on combination of statins and ezetimibe, and 13% were on PCSK9s, finally lamidipide, 5%, and only 1% on lipid or lipoprotein apheresis. So what are some red flags, we call it, of identifying this homozygote FH? Well, obviously family history is a major player in this because it has to come from both parents, and family history should be correlated to increased cardiovascular disease at a young age. And the LDLs for children for FH could be above 160 to be in a category of considered FH, and in adults over 190. Physical exam findings, you have the so-called plantar xanthomas on the hands and buttocks, tuberous xanthomas, ocular exams show this cornea arcus, which will show, here you go. Here's a cornea arcus, which is cholesterol laden on the cornea arcus, and this is called cornea. This is arcus lipidalis or arcus juvenalis. There's an arcus sinalis that you get at old age for patients who is not necessarily associated with FH, but just old age. The good thing about this diagnosis, it has no significant effect on vision. This is why ophthalmologists don't usually bring this up to patients if they find it in their physical exam. Xanthelasma is the cholesterol plaques you can see here on the eyelids. You have xanthomas of the extension tendons that I mentioned. Also, previously removed xanthomas. I've had patients sent to me who had their xanthomas removed by surgeons, not realizing if you don't treat the disease, they're going to come back. Thickening of the Achilles tendon is classic for homozygous FH also. Now, diagnosing HoFH and performing cascade testing. So the best diagnosis is testing, obviously, for dyslipidemia and LDLs. And after age 2, roughly, children's cholesterol is their own. They've now moved on to having their own type of cholesterol. And the recommendation now is universal testing for everybody by age 9-11 in the United States. That's the guidelines. But those with family history of FH should probably be tested sometime after age 2. And any LDL greater than 400 should be prompt evaluation of homozygous FH. Even something in the 200-300s that tells you this person at this age has something going on. And as I said, universal screening for everyone is recommended around 10 years of age. And I mentioned physical findings, of course, too. Now, the differential diagnosis of HoFH, in addition to the homozygous severely elevated LDLs, I mentioned also some of these other ones, cytosterolemia, which is a rare genetic disease that causes plant sterols to accumulate in the arteries, and the LDL levels can go up to mask the presentation of that. And that's mistaken as a FH, which is not. Polygenic hypercholesterolemia, meaning you can have multiple genetic factors that phenotypically look like HoFH, but genotypically they're not. They're associated with multiple different types of genetic abnormalities. And then vascular diseases can associate with this, such as hypothyroidism, can increase it, nephrotic syndrome, liver disease, particularly cholestatic liver disease. When you have extrahepatic cirrhosis, your liver develops what we call as lipoprotein X syndrome. It's an LDL that's twice the size of an LDL, and the numbers can go over 1,000, but they have no ApoB. Therefore, they don't cause atherosclerosis per se, but because of their large size and number, they can increase the risk of the hyperviscosity syndrome that could be seen in some of these patients. And lowering it is actually, in these cases, lowering the disease that's causing this is the way to treat these. Another abnormality of lipids found in FH patients, not commonly discussed, is not only the LDL. Here's looking at normal patients with LDLs about 110, heterozygotes in the low 200s, homozygotes, in this case, very high, but HDL. And you can see HDL in a normal individual in the 50s, where heterozygotes can be in the 40s, but homozygotes can have HDLs in the 30s. And it's not discussed very often. And that HDL seems to be associated, at levels that is, due to apolipoprotein E4. And apolipoprotein 4 is based on the isoforms of E2, 3, and 4, which we get from our parents, their genomes. And if you have ApoE, you could have ApoE2, 2, ApoE2, 3, 3, 4, 4, 4, so forth and so on. So you have 6 variants. And obviously, ApoE4 is commonly known with dementia, but it's also associated with cardiovascular disease. In this case, it's associated with low HDL in this patient population of FH. You can see 72% predictability and p-value of 0.003, where age has a modest correlation. As you get older, the HDLs can go down. Gender has, in this case, non-significant. It's mainly the ApoE4 that dictates the HDL levels in these patients, but not only in their function, which I'll show you in their levels, but also in their function. So here's the ApoE3. It's normal lipid metabolism, no cardiovascular disease risk. ApoE2 has some risk, but it's the ApoE4 that has our highest risk associated with cardiovascular disease. FH patients have decreased levels of HDL-C, as I mentioned. They also have decreased ApoE1 and ApoE2, And they have a 5 to 10-fold increase of ApoE-rich HDL, and most of the ApoE-rich HDL is ApoE4. And an ApoE4 phenotype may encompass up to 50% of total ApoE, compared to the general population, which only 25% have an ApoE4 genotype and isoform in their system. And having the ApoE4 isoform increases the prevalence of ischemic heart disease by more than 70%. So besides being a risk factor for dementia, Alzheimer's disease, it's also a risk factor for cardiovascular disease. And amazingly and not surprisingly, that ApoE4 has also been shown in studies, and this is one that we published 7 years ago now, looking at patients' ApoE isoforms, E2, E2, E3, E3, 4, 4, and saw that ApoE4 patients have a much higher level of lipoprotein A or Lp(a), which is another genetic dyslipidemia, and predominantly 70, maybe more than 90% is genetic, and some genetic factors may influence it, like chronic kidney disease, because partially the Lp(a) is degraded in the kidney, so we think that if you have kidney disease, the Lp(a) goes up. Liver disease may decrease it. Hypothyroid might increase it. Menopausal women, it increases during menopause because estrogen lowers Lp(a), just like testosterone does. And interesting, acute phase processes can transiently increase Lp(a). For example, pregnancy raises Lp(a). And it's found that high Lp(a) is found commonly in preeclamptic women. And there's a limited effect on diet and exercise for Lp(a)s, meaning it doesn't correlate to exercising or dieting in a sense of reduction of levels. And why this is important? Because the commonality of Lp(a) compared to FH is exceedingly higher. In the African population, 30% of individuals have a so-called elevated Lp(a). South Asians, and particularly in India, have a 25% probability, where Europeans is 20%, and the rest of the world is a variation. China and Japan have the lowest level, about 10% compared to the rest of the world's population. And when you associate high Lp(a) with FH, that's a very bad combination. You can see in this recent study in Frontiers in Genetics, looking at patients over a time period of 5 years who had neither FH or Lp(a), this was their probability of death due to ASCVD events. And then you look at groups that had elevated Lp(a) or FH alone, they're around the same. But when you had the combination of two, look at how high the hazard ratio jumps up in these patients in just a 5-year period. So it's a very bad combination to have both of these together. And the association of vascular disease risks are related to Lp(a). This is a recent paper by Grunenberg and his group, which I was a co-author of this European Heart Journal, looking at their guidelines, showing that aortic valve stenosis, ischemic stroke, myocardial infarction, and heart failure all are associated with Lp(a), and the higher the levels, the more prevalent the absolute risk is for this patient population. Because of the prevalence of this risk factor and the lack of change over time generally for normal people, the guidelines have become a lot more aggressive in a sense of treating and diagnosing these patients, well, at least for diagnosing. And this is the multi-center cholesterol guidelines from 2018. They said, you get risk enhancer, but they said no universal screening. But since then, the European Society of Cardiology, the ESC, the Canadian Cardiovascular Society, Dyslipidemia Prevention, the European Atherosclerotic Society, and now the National Lipid Association this past year, finally, all have agreed that universal testing should be performed in adults over age 18. And actually, I think it probably should be done even before then, which it probably will be eventually, to see if you have this risk factor. Now, initiating treatments for patients with newly diagnosed HoFH. Well, let's go through some of the standard therapies and see how they affect the LDL receptor activity. Statins specifically go after the LDL receptor as the primary effect. They also affect HMG co-reductase, which lowers LDL, but the major effect is the LDL receptor activity, which increases the degradation of LDL in the blood system. And it works for both HeFH and HoFH. Cholesterol absorption inhibitors such as ezetimibe, and work in the gut, but they also increase LDL receptor activity, which is what you want, and they're roughly 15%, 10%. In the general population, they're about 20% LDL reduction. PCSK9 inhibitors, their primary benefit is lowering PCSK9, which is that protein I told you about that destroys LDL receptors. So by getting rid of the PCSK9, the LDL receptor activity and longevity lasts longer. Usually the liver, the LDL receptor takes in bad cholesterol into the liver. They separate, they go back to the surface to bring in more bad cholesterol. They can do it about 100 times or so. And by getting rid of the PCSK9, it can extend itself. And you can lower LDL by 55% in HoFH and or 25% in HoFH, depending on the situation. Lomidopide inhibits this microsomal triglyceride transfer protein, or MTP, and it has roughly about a 50% reduction of LDL. Bempedoic acid, which recently became approved, also increases LDL activity. It's kind of like a statin, but it's a prodrug until it gets into the liver, where an enzyme activates it in the liver to do its job of reducing cholesterol metabolism and also increasing the LDL receptors, and it lowers LDL by 20-30%. Evinacumab works by increasing the catabolic rate of IDL, ApoB, and LDL. And like lamidopide, it lowers LDL to about 50% in both groups. And finally, lipid apheresis, it probably removes LDL, which I'll go into in detail. And it increases LDL receptor activity as a secondary mechanism. And chronically, it lowers LDL by 20-40% and up to 70-80% acutely. The good news is there are newer therapies under investigation for further LDL reduction for FH patients. There's one here that's just a adeno-associated viral vector, serotype 8, which mediates replacement of LDL receptor gene. It's in phase 2 right now. There's an antisense oligonucleotide that targets PCSK9 directly, and this is in phase 1. This exosomal LDL receptor mRNA replaces the LDL receptor with mRNA, and that's in phase 1. And finally, the CRISPR technology, this is the Verve 201. It's an mRNA-mediated gene editing of angiopoietin-like 3, which is in preclinical level, but it looks promising itself too, and they're on the horizon. Let's get back to the basics. How do we treat an FH patient? Most often, it's combination therapies. The routine lipid-lowering therapies work through LDL receptor, lower response than typical hypercholesterolemia. So initiate with a statin, then you add on ezetimibe over a period of time. If it's still not a go, which they probably won't be, then you can try a PCSK9 inhibitor, an by antibodies or siRNA, inclisiran, and bempedoic acid, added on to that, recently approved. And finally, other pharmacotherapies, lamidopide and evinacumab. And if this doesn't work, then you move on to lipid apheresis. Now, when you have HoFH, I told you that there's different mechanisms are related to that. Drugs are related to being dependent or non-dependent on LDL receptors. So statins that require LDL receptor functionality, such as statins, ezetimibe, bempedoic acid, and PCSK9s, because they up-relegate the lifespan of the LDL receptor. So if the defect with the FH is related to that, then you need these drugs to work quite effectively. Some defects, such as the ApoB I mentioned, which is about 4 or 5% when you have a defective ApoB lipoprotein bound to the LDL, because it's defective, it doesn't recognize the receptor. So even though you might have receptors that are functioning, because the ApoB is defective, it might not recognize it. Therefore, your LDLs will still might be elevated in the vascular system. So treatments that don't require functioning LDL receptors, obviously if you change someone's liver, that's a whole new deal. An ileal bypass, a lipid apheresis, a lamidopide, and evinacumab don't require the LDL receptor as the primary need for lowering LDL. Now, going back to the Lp(a) story, the only therapy approved by the FDA for treating Lp(a) with cardiovascular disease is lipid apheresis. And it removes Lp(a) similar to the LDL in the sense of acute and chronic reduction. And there's quite a few, and I'll show you some studies on that. Nicotinic acid has been tried over the last 30, 40 years, lowers Lp(a) by 20, 30%. But unfortunately, its outcome data has been very poor in the sense of correlating the reduction of events with the reduction of Lp(a). In fact, in Europe, it's been banned as a drug of choice because there's been signs that might actually worsen situations, because high dose niacin can raise uric acid levels, which is associated with gout, but also inflammation, which has been associated with cardiovascular disease risk. And high nicotinic acid can raise your glucose levels. So the adverse side effects could be more detrimental than the benefit it appears like. PCSK9 inhibitors are not approved, but have been shown to lower Lp(a) by 14 to 30%. Mechanisms not totally sure. Maybe decrease the secretion of ApoA, but it's been shown to be, and I'll show you trials about that. Mepomycin is a drug that's taken off the market. It's inhibits ApoB100, lowered Lp(a) by up to 40%, but again, it's taken off the market. Lomidopide has a modest reduction, nothing dynamic. It decreases VLDL synthesis, as I told you before. And statins actually raise Lp(a) by 8 to 24%. Mechanism is not fully understood in that either. And I'll talk about that with trials. Ezetimibe and fibrates and bile acid sequestrants, they have really no effect on Lp(a). So the only apheresis process that's approved in the United States is the so-called dextrin sulfate system. And basically, blood's withdrawn from into cubital veins at a slow rate of less than 100 cc's a minute. Heparin pump is for anticoagulation. The plasma is separated, and the plasma goes through the so-called dextrin sulfate filters, which are negative charge because ApoB is a positive charge molecule. So the dextrin sulfate binds the ApoB, and then they're returned back to the patient with the blood of the patient that was removed earlier. And 3 to 4 liters of plasma is treated at one time. It takes 2 or 3 hours, and treatments every 2 weeks or so, depending on the patient's risk and levels and response. And the FDA approval for this treatment is based on 3 categories: FH with LDLs greater than 300 without vascular disease and max pharmacotherapy; FH with documented vascular disease, CAD or PAD, with LDLs still over 100 milligrams per deciliter despite pharmacotherapy; and finally, HoFH and with documented coronary disease and PAD with an LDL over 100 and an Lp(a) greater than 60 milligrams per deciliter. They're approved for apheresis for that. Now, in Germany, which treats 10 times more patients with lipid apheresis than the United States, even though they're 1/6 the size, has dramatic data on their benefit of treating Lp(a) in patients with isolated Lp(a) and cardiovascular disease. So this is analysis by Volker Schettler and his group, published in the Therapeutic Apheresis Dialysis Journal a few years ago, looking at these patients over a 7-year period whose baseline LDL was less than 100 and Lp(a) was greater than 60 milligrams per deciliter. And you can see this is their event rates before starting apheresis, and after 1 or 2 years, their event rate dropped by 83% and was sustainable throughout that time period. So not only lowering it acutely, chronically it stays stable with these patients by treating them with this lipid apheresis. And besides just lowering these lipoproteins that apheresis does, it also has effect on other parts of the vascular system. It reduces blood viscosity by 20-30%. So blood being a non-Newtonian fluid, unlike water and plasma, a higher viscosity can affect the resistance to flow of that blood. So I tell my patients we're changing the blood from like ketchup to tomato juice. It also alters the quality of HDL, which I'll go into shortly. It lowers vascular inflammatory markers such as CRP, fibrinogen, interleukin-6, galactin-3, and it's approved for HoFH, HeFH, coronary disease, cardiovascular disease, PAD, and recently FDA approval for focal segmental glomerulosclerosis, which is a kidney disease related to pre or post kidney transplants of unknown etiology, but apheresis seems to be the best therapy for that, based on Japanese data that approved in the United States. And there are other disease processes potentially considered in this category too that are under investigation. So about the HDL functionality, this is looking at apolipoprotein E4 bound to HDL, the study we did years ago looking at pre and post levels of LDL, total HDL, and ApoE4, and we found a dramatic reduction of HDL, but it was strongly associated with the reduction of ApoE4. So the HDL we were reducing was that ApoE4 bound HDL, And ApoE4 isoform, unlike ApoE2 and 3, is more positive charge. Ergo, the negative charge dextrin sulfate pulls it out more readily than the ApoE2 and 3, it appears. And talking about inflammatory markers regarding lipid apheresis, you can see an endless amount of these markers, CRP, fibrinogen, and so forth, being dramatically reduced, oxidized LDL with lipid apheresis. So there's a vast vascular benefit associated with apheresis besides just lowering an LDL or an Lp(a). Now let's go back to statins, because I talked about statins actually having a potential effect of raising Lp(a). And the question is, well, should I have someone on a statin if they have a high Lp(a)? And the answer is yes. This is studies from Paul Rickener's group looking at Jupiter trial, patients with high-risk primary prevention with LDLs on rosuvastatin or placebo. And they showed that the rosuvastatin lowered LDL quite dramatically from 108 to 54, and the risk of cardiovascular disease was reduced by 44%. So after the study, they said, well, let's look at what happened to Lp(a) patients who had high Lp(a). How did they do in this trial? Since the drug might raise the Lp(a), did they do worse off? Well, they didn't do worse off, but their event rate was attenuated. So meaning the primary endpoint, which was MACE, in the group that had the low Lp(a), they had a more powerful benefit, but the group with the high Lp(a) still had benefit. It was just attenuated. And when they looked at the primary endpoint, including cardiovascular mortality or total mortality, it was still significant, even though it's attenuated compared to low Lp(a). So the answer is yes. Patients who do have high Lp(a) and do need LDL reduction, the statins do help, even though there's a modest effect on the indirect effect on the Lp(a) potentially. PCSK9 inhibitors. Fourier was a study looking at patients with cardiovascular disease and using a PCSK9 inhibitor, in this case, evolocumab, and following them for a period of time, looking at cardiovascular output, and they showed benefit. But interesting, when they broke down the groups to Lp(a) of a low-medium level to Lp(a) of a high-medium level, the ones who had the high Lp(a), their number to need to treat to prevent an event was 40 compared to the ones who had normal Lp(a)s, which was under 5. They then said, let's break it down to Lp(a)s above 120 nanometers per liter, nanomoles per liter, compared to 120 nanometers above per liter. And again, they showed similar number needed to treat levels dramatically improved by the higher Lp(a) level in treating these patients. So PCSK9s in this case showed a benefit. When you looked onto the other study, the Odyssey outcome trial, which was using the PCSK9 inhibitor alirocumab, they broke down the baseline quartiles of Lp(a) from very low, in this case, 9, then up to higher, and finally up to a higher level of the highest quartile. And they found the patients in the highest quartile had a significant benefit in reducing cardiovascular disease compared to patients in the first or second quartiles. So yes, patients on with high LDL and high Lp(a), PCSK9 inhibitors have been shown to be quite effective and should be considered in your patient population. At least you should measure their Lp(a) to make sure they have it or don't have it. Before we move on to other data, let's watch a short video on how the mechanism of action of HoFH treatment options can be available.
Patients with HoFH typically have insufficient responses to most recommended lipid-lowering therapies, such as statins, ezetimibe, bempedoic acid, and PCSK9 targeting agents, which depend directly or indirectly on functioning LDL receptors. Because their LDL receptors work ineffectively, are few in number, or are completely absent, patients with HoFH need lipid-lowering treatments that work independently of the LDL receptor. The body generates and utilizes varying sizes and densities of lipoproteins. Less dense lipoproteins, like LDL, are atherogenic, but increasing evidence supports that triglyceride-rich lipoproteins, such as intermediate density lipoprotein, or IDL, and very large low-density lipoprotein, or VLDL, may also be strongly associated with atherosclerotic risk. Although the exact mechanisms are still being investigated, Angiopoietin-like 3, or ANGPTL3, a glycoprotein produced by the liver, regulates hepatic secretion of triglyceride-rich lipoproteins. Irrespective of the LDL receptor, ANGPTL3 suppresses lipoprotein lipase, or LPL, and endothelial lipase, or EL, which are central mechanisms for clearing triglyceride-rich lipoproteins from the circulation. Evinacumab is a fully human monoclonal antibody that inhibits ANGPTL3, thereby increasing LPL activity. This promotes triglyceride hydrolysis of VLDL, leading to reduced production and increased clearance of LDL-C. In patients with HoFH without functioning LDL receptors, especially those with null-null mutations, inhibiting ANGPTL3 appears to reduce LDL-C through EL activity. This remodels VLDL, resulting in remnant particles that are rapidly cleared and depletion of LDL-C precursors. Consequently, evinacumab can reduce LDL-C by about 50% in patients with HoFH.
Let's go back to some of the recent medications that are approved for HoFH, like limidipide. It's looking at long-term data, 250 weeks, looking at the LDL reduction and the change from baseline. But you can see quite dramatic reductions in the patients here. It's a very good drug. It does have some GI complaints that they sometimes have. You got to be careful of that because it's effect on that on the GI system. But generally, it works by lowering LDL about 50%. And evinacumab, again, has about a 50% reduction in LDL. Long-term, in this case, it was 44%. And regardless of LPLA levels, it still lowers it by a similar amount and quite safe. It's an infusion once a month therapy, the evinacumab. And this is in pediatric patients, which one of my patients was involved. She was a young girl, came to me with an LDL over 900, and she had no receptors, so she was non-responsive to anything. And getting her on apheresis, we were able to get her numbers down into the 400s, 400s, low 300s. But once this study came about, we added her to this trial. And you can see the dramatic reduction this drug class has, 50% reduction across the board. And now this young girl that's in her LDLs are in double digits on apheresis and evinacumab and doing quite well. Again, that's an infusion therapy once a month. So why don't we look at some algorithms for treating these patients? We kind of went through that fast, and let's go after it a little bit more in detail. Let's say patients are on maximally tolerated statins, and they're at goal, then great, which would not be common. But if they're not at goal, you do ezetimibe. If they're not at goal from there, bempedoic acid, PCSK9s. If they're not at goal again, evinacumab, then limidipide, and then lipid apheresis if it's still patient is not at appropriate goal. And you can start pediatric patients early on these therapies at age 10 now, based on the safety of some of these medications and the necessity of getting them to goal. In combination therapy, this is looking at examples of statins with ezetimibe. You get about a 50% reduction there. You have patients on bempedoic acid and PCSK9 inhibitors, and you can get a very good addition there. And this is looking at evinacumab and limidipide. Again, very good combination reduction. And then you get the whole kit and caboodle. You can, hopefully, in some of these patients, you can get their levels down from the close to 600, possibly down to double digits. They respond well to this medication. Okay, individualizing treatment of the HoFH patients. Let's look at different therapies, lipoprotein apheresis, limidipide, and evinacumab. Now, for lipoprotein apheresis, you need an outpatient clinic. In the limidipide, it's oral version. Evinacumab, as I mentioned, it's once a month infusion. Frequency is for lipid apheresis 2 to 4 times monthly, more often 2 times monthly, once daily for limidipide every 2 hours after evening, and I mentioned once a month. Any age, well, apheresis, you have to be about 5 years of age and a certain weight before you can start it. So limidipide hasn't done those pediatric studies of early age, like evinacumab, which has now been shown to be safe and effective on patients 5 years and above. No box warning for lipoprotein apheresis. Limidipide can have some hepatotoxicity, and I mentioned the GI problems. And evinacumab is fairly safe and very, very little, if any, adverse box warnings to think of. REMS is not available for LDL-A. You know the other ones. Common AEs report for apheresis, and like any access, you could have some episodes of hypertension. Anaphylactoid reactions is common, and IV access is the most common one in these patients. And for limidipide, again, the GI complaints, diarrhea, nausea, vomiting, dyspepsia, abdominal pain. And evinacumab, similar to PCSK9 inhibitors, nasal pharyngitis seems to be the most common adverse side effect related to this. When it comes to contraindications, lipid apheresis has been shown to be effective in patients who are pregnant. We've treated quite a few pregnant women in our clinic, and pregnancy is not approved therapy for limidipide or evinacumab, not due to adverse side effects per se, but due to clinical trials examining them. So it's still like unknown what should be done. So it's not approved for that patient population. Now we have some case studies. Here's Katie, a girl aged 11 years old with severely elevated LDL. Her LDL is 755, and obviously that's a HoFH range, and a fasting lipid panel was not too far off. Exam revealed palpable nodules on the extensor tendons in the hands. Obviously, the diagnosis of HoFH was not too difficult to come to conclusion. We still do in our clinic, we do clinical genetic testing on patients like this to get an understanding of the type of gene defect is occurring in these patients. Some insurance will cover that. Not all will, but some will, especially if you have family members who already have it, which this most commonly do. And I think it's going to become more prevalent and much cheaper in the future to do genetic testing. So what do we discuss here? What is the reasonable for non-specialist clinicians to do while waiting for referral to a lipid specialist? Well, obviously, you treat the patient. And I would probably put her on a statin to see how she does as the initial therapy. In some of my young non-FH patients, I put them on a statin once a week to see how they do, like a rosuvastatin, 40 milligrams once a week, just to see how well they do. Because the plasma half-life of rosuvastatin is 24 hours, but its tissue half-life, it's 2 or 3 days. But for an FH patient, you probably should start you do a low-dose statin or whatever, depending on the patient's delicateness, and see how they do. And the goal, well, the perfect goal is as low as you can get. But in this case, it depends on the situation with the patient history and family history. But getting as low as you can is the priority. What treatments can be used in what sequence? Well, I showed you that whole before. You start with the statins, add ezetimibe, bempedoic acid, or PCSK9 inhibitors. Consider limidipide, evinacumab, and last but not least, lipid apheresis, particularly if they have a high LDL-A and they have disease on top of that. And which family members should be screened for FH? Well, all family members should be screened. If they have a genetic family history of someone in the family, they should be screened for FH. As we talked about previously, that everyone should be screened, universal screening by age 10 for all patients, FH or non-FH. Here's another young man, Jamel, with elevated LDL. He was diagnosed with idiopathic hypercholesterolemia, LDL of over 400, after a sports physical 4 years ago, initiated on statin therapy and with minimal LDL reduction. His current medications include high-intensity statin, ezetimibe, and PCSK9 inhibitor. So his LDL now is 133. So what are the next steps in dealing with this patient? Well, in this situation with genetic or non-genetic, I always deal with lifestyle, diet and exercise. I have my own dietitian that talks to this patient to discuss further benefit in the lifestyle, because I tell them you can't beat your genes, but you can delay your genes from beating you by living a good, healthy lifestyle. And I would probably recommend genetic testing, because for this patient, not only him, but also his family and his potential future family, if he gets married and has children. It's important. And would you suspect HoFH after statin failure? Well, I mean, if he has an LDL of 400, he has FH, unless it's some other secondary, like we talked about, lipoprotein X syndrome or hypothyroid or other secondary etiologies, but he probably has it. And it's statin failure, as we showed, the statin benefit of lowering LDL in FH patients, particularly HoFH, is not as powerful as it is in non-FH patients. Would you refer this patient for treatment with evenacumab and apalutamide? Yes, if you do not want to treat it, or you're not able to treat these patients with this kind of class of drugs, and they've been on ezetimibe, high-intensity statin PCSK9 inhibitors, I would refer this patient for treatment, or diagnosis and treatment with these medications, and potentially for apheresis. The problem with apheresis in this country, there isn't many centers, as you know. As I said earlier, Germany has 10 times the amount of patients than we do, even though we're 6 the size. Here at KU Medical Center, we have the largest lipid apheresis center in North America. And we treat more patients at KU than all of Boston, New York, Chicago, LA combined. And it's not because of a plethora of these patients. It just hasn't caught on, this technology in therapy for these patients. Unfortunately, because there's a wait for new medications, which hopefully will come around. But in the meantime, this is the best treatment in town for combination LPLA, LDL for patients like this. Let's move on to another case study here. This is Roger, a 48-year-old with confirmed HoFH, and he was diagnosed 12 years ago by genetically confirmed pathological variant of HoFH. And his office visit for protracted nausea was what he was being seen for. And his recent laboratory work revealed a pattern of increasing elevated liver enzymes. His current medications were moderate intensity statins, ezetimibe, because he was on moderate intensity because he couldn't tolerate the high dose due to AEs. He was on ezetimibe also, PCSK9 inhibitor, and added lamidipine. And his LDL was at 84 milligrams per deciliter. So close to goal, but not quite enough. So what questions you'd have is, would you recommend any changes to his treatment regimen? Well, he's having these GI complaints, and he's got elevated liver enzymes, and that could possibly be related to the lamidipine, which I brought to you earlier, that has GI complications related to it. So you might want to hold the lamidipine and see how his symptoms and his enzymes change. And if they do improve, then you might want to go on to another level of therapy and maybe add a bempedoic acid. And you can do a combination bempedoic acid ezetimibe. So you're not really adding, you're just switching the ezetimibe with the combination of bempedoic acid and ezetimibe. And if you get to go with that, then all's fine. If you're not, then you might need to consider, and depending on his medical status, meaning doesn't mention here he's got cardiovascular disease or not, but you might require lipoprotein apheresis. And your lipid specialist would be obviously greatly involved with this with you, and therefore would work in conjunction getting to the right goal. Okay, now let's move on to hear an actual patient living a very long time with HoFH and listen to her story of her experience dealing with this disease.
And then from college, I went into the military. So I had to move around, and I found myself in front of different doctors. And I cannot tell you how many times I would sit in front of a doctor, and when they say, tell me a little bit about yourself, and I would start explaining to them that I used to have this cholesterol level at 1,000, they looked at me like, yeah, right. Like I was lying. And I actually had a doctor tell me that's impossible. And I drove from Fort Polk, Louisiana to Johns Hopkins without an appointment to see somebody from the lipid clinic. And when I got there and told them my situation, they were just quite amazed. And they says, well, we're going to need to test you to make sure you know, your levels are high. I was very fortunate that my test results proved that I wasn't lying, but they were able to help me. And then from there, they started me on the LDL apheresis, which actually had more of a positive impact than anything else. Eventually, what happened after so many treatments, I started developing scar tissue in those areas where my good veins were. And scar tissue is mad, awful, painful. It's extremely painful when someone tries to stick a needle in scar tissue to try to get to a vein. I used to scream my head off. And then they give me Imla cream to try to numb it so that I wouldn't feel so much of it. But that was absolutely, even though it was necessary, it was absolutely awful. And then eventually they says, well, you know, we can't keep sticking Patricia this way. She's in too much pain. So then someone came up with the idea, well, we have dialysis patients that have this problem, so someone suggested that I get a fistula put in my left arm. So I got the fistula. However, what I didn't realize was going to happen, I don't think anyone else realized, my fistula continuously kept clogging because of the plaque in my blood, the fat in my blood. So I had to many times go in the hospital to have the plaque removed from the fistula so that it could be used. And it kept clogging and they kept opening up my arm. They opened up my arm so many times to try to clear that artery that eventually it caused complications for me where I lost feeling in my left hand. My hand is numb. My left hand is constantly swollen. I now have to use pain cream and pain pills because the pain now is so bad. And it's at a point now the left arm can't be used for anything. So that was one of the downfalls to the LDL apheresis, as much as it helped me. The only bad thing that happened to me on the LDL apheresis, and it was ignorance on my part, but probably lack of knowledge on the nurse's part. I went in for treatment at the University of Pennsylvania, where I was going at the time, because I've had treatments there and Johns Hopkins. And I was on a lot of medication, and one of them was an ACE inhibitor. No one ever told me not to take an ACE inhibitor before the LDL apheresis. Well, I'd taken my medicine. They started the machine, and I thought I was going to die. It's like my head was spinning. I felt like I was getting ready to faint. I was screaming at the nurses, somebody help me. I thought I was dying. And they immediately stopped the machine, flipped me back in the bed where my feet were up, and whatever else they did to me, I had to stay there for a while until I got myself together before I could leave. And once the nurse started questioning me about what I ate, what medicine I took, finally one of the nurses says, "You should have never." I said, "No one ever told me." And so then after that, every time I went for an LDL apheresis treatment, they always said, what medicines did you take? Which should be something that they should always do before they start the treatment for anybody. Because one thing I want everybody to realize, I'm about to turn 68. I've gone through a lot of treatments. I've had surgery. I've been on every medicine ever they have ever made for high cholesterol. And I'm told I'm the oldest living person right now on record that has HoFH.
Okay, quite a story by Patricia, and a gallant story of survival, I have to say. And her history is like, a history of lipid therapy in the past 60 years. You can see in 1965, she had the ileal bypass, and she was put on propofol and clofibrate. Clofibrate is another version of fibrates, like fenofibrate, that doesn't lower LDL per se, at least not being used in the United States anymore. And propofol also is not used in the United States. It does lower LDL by inhibiting the synthesis and increases the degradation of LDL, but also lowers HDL and has some QT interval in the sense of arrhythmias potential harm. And in Europe, after the statins came out, propofol was taken off the European and American market. It's still used in Japan. And actually, the HDL goes down. Actually, it improves HDL functionality in the sense of reverse cholesterol transport, and it's good anti-inflammatory drug. So it does have some benefit. And then later on in the 80s, we started getting bile acid sequestrants, resins, cholestyramine, and so forth, which have a modest effect on LDL, but can also raise triglycerides indirectly. Then niacin, we talked about. And finally, the first statin that came out, lovastatin, came out in the 80s. And then plasmapheresis was started, which is this simple plasma exchange where they take out all the plasma and replace it with donated plasma. And unfortunately, unlike lipid apheresis, plasma exchange takes out your HDL. So your HDL gets dropped by 50 to 60% with the plasmapheresis, unlike the lipid apheresis, which selectively takes out certain HDLs and all the other apoB-like proteins that I talked about. So it's not as selective as lipid apheresis is. It's more of a non-selective process of just taking out everything. And then you can see her LDLs drop dramatically with the apheresis. And then finally, she was put on evolocumab, which really did a great job. And lipid apheresis, the device I mentioned earlier, they use a dextran sulfate filter, and it causes an increase of bradykinin levels 900-fold. And bradykinin, as you know, is a very strong vasodilator, and it can cause hypotension. And if you have an ACE inhibitor, which can also increase bradykinin, the combination of the ACE inhibitor with lipid apheresis that really is contraindicated. I put all my patients on ARBs. And venous access that this young lady had, unfortunately, and all the clotting could be related that she probably had a high Lp(a) and never got it measured. I didn't see that in her history, that Lp(a) is measured. And in these patients, the fistulas can get kind of abnormally large. And as I said, you only need a needle, 18, 20 gauge needle can do it. And the flow rate's less than 100 cc's a minute. What we're using now, a lot of these patients are these so-called BARD ports they put underneath their skin and their chest, which work quite effectively. But it's amazing how well she's been doing for these last 60 years. Quite a story. Now, referring patients to specialty care and navigating insurance requires normal therapies. That's for sure. And so as a PCP, you do systemic screening, optimistic screening, cascade testing for family members, which I agree you should do or recommend that they get tested, particularly the Lp(a) too. Don't forget that. Refer to a specialist if LDL is greater than 160 or an LDL greater than 190 in adults and Lp(a) greater than 75 nanomoles per liter. Special assessments provide information supporting genetic counseling, genetic testing if it's available, obtain three-generation pedigrees, offer DNA tests to confirm diagnosis. I agree with that. And ongoing management, intensified lipid-lowering therapy until LDLs are met at goals. And again, I offer lifetime lifestyle advice and interventions, because if you live a not healthy lifestyle, then with genetics and a bad lifestyle, that's a bad combination. Specialist management annual visits to assess LDL goals. I see them more often depending on my titration of the therapy. Specialist management if goals are met on combination lipid-lowering therapies accessible to non-specialists with very high ASCVD risk. So I think, depending on your expertise and your willingness, I think a lot of PCPs can deal with the majority of this in the beginning and getting these patients treated in that goal, and then if need be, move on to a higher level, especially that might require more intensive therapy, including lipid apheresis. Now, best practice in obtaining access in lipid-lowering therapies that require prior auth. Well, the importance here for getting prior auth is twofold, I find. One is getting a peer-to-peer with that insurance company that you're dealing with, if it's possible, to sit down and talk to them over the phone the situation of your patient and the priority needed. And if you get a person that's a physician who's in the field that you're in, like a good internist or something of that nature, or cardiologist, or not even that, then the understanding is there and their support will be with you. State, maximum tolerated statin dose, and list current and prior lipid-lowering therapies, obviously give that background. Another thing is have good pharmacy specialists. These pharmacy specialists have a good way of getting approval from the medications and also getting the price at a reasonable rate. And I find and accessibility very good. So here at our university, we have a slew of pharmacy specialists who help get my patients approved for, be it a PCSK9 inhibitor, omidopide, olecmab, and so forth. The apheresis is something I have to do. I have to go peer-to-peer to get that approved. But we've been doing fairly well. We have 75 patients we treat regularly with lipid apheresis in our center. Appeals and access academic medical centers report 97% approval rate, which is very good, of course. But 20% of prescriptions require at least one appeal. I'd agree with that. And combined insurance with foundation grants, Medicare typically covers 80%, as you know, and supplemental policy covers maybe 10 to 15%. So patients still might have to pay a little cost for what the therapy is. But clinical pharmacists, as I mentioned, and these specialists, they call them, can be very instrumental in getting access and getting coverage for these patients. So this will end our discussion for today. And I hope you found the activity informative and useful to your practices. But don't forget to download the practice aids and slides for this activity by clicking on the appropriate icons in the menu. Thank you for participating in this lecture and listening to a discussion on this very important topic of FH, both heterozygote, homozygote, and high Lp(a) and cardiovascular disease risk prevention. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Family Heart Foundation. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/MRJ860.